it's Mick Hughes here, co-founder of Learn.Physio. We've just completed our first month of the Teams program and we've got great reviews from those involved. What you're about to see in this short video is an example of a standard month of the Teams program, consisting of a masterclass, a practical session and a live Q&A. First up, we've got Julian Fellow and Randall Cooper discussing non-operative management of the ACL from their ACL masterclass.
I threw this question in as a sort of provocative question. Is non-operative management of ACL injuries a fad? Because clearly it's getting a lot of airplay in social media and a lot of patients talk about it and they all know about the footballer down on the Mornington Peninsula who played without an ACL. They know about the AFLW player who tore a graft and played without a graft. The last Olympics, we heard about how many people were performing without an ACL.
Premier League player. I set it all off back in about 15 or 16, wasn't it?
Yeah, exactly.
Yeah.
So my response to, is it a fad? The answer is no, it's not a fad. It's always been there. And so as I mentioned, 1990 was my last year of orthopaedic training. I was at the Austin Hospital under John Bartlett, and that's really where I sort of started to become really interested in knees. But the training back then, when you saw someone with a torn anterior cruciate ligament in the outpatient clinic, was basically there were three groups. There was a group who definitely needed an anterior cruciate ligament anterior cruciate ligament reconstruction, because they fell into that very active group who wanted to go back to sport, be it footy or netball or soccer, basketball. There was a group who were very unlikely to need it. There was a bit of a freak injury, who wasn't playing their preferred sport. They might have just gone back and played one game of fill-in netball, 20 years after they last played, sort of thing. And their knee isn't very loose, the demands aren't very high. And then you've got the middle third where you don't absolutely know whether they need a RICO or not. And that's the group where you can call it non-operative treatment or a trial of non-operative treatment or just see how your knee goes. If it becomes unstable, then I'll say to the patients, and as I mentioned before, I'll say, you'll know what I mean, it'll be this sort of sensation. And then I'll say to them, you've then got a choice. You can't keep doing that activity and having that feeling. So you can either give up that activity, or if that activity is really important to you, then you'll need a reconstruction. So I think that the other thing that's made it difficult has been MRI being so readily available, and the reporting is variable, I'd have to say. And so I never ever rely on the report of the MRI, and that's fine for me. I'm a specialist.
You also look at the scans?
I always look at the scans. In fact, I don't even look at the report, to be honest.
Right.
Sometimes when the patient's quizzing me, because they've always read the report, what about that meniscal tear or that root tear of the the root tear of the lateral meniscus? And I think, I didn't see a root tear there. And I'll go back and have a look, read the report, and I'm happy to disagree with the radiologist, but I'm in a very sort of specific situation where all I'm doing is looking at knees all day, looking at scans. So I'm not saying to the physiotherapist, you need to be able to interpret the MRI, you've got to trust the report. But you get sort of fuzzy wording, high-grade injury, to the proximal end of the ACL. And what does that really mean? It's the radiologist sort of backing both horses, if you like. And the way I see it is, the way I look at it is, yes, you've torn your ACL, but are the fibres sort of still roughly aligned? Is it a true partial thickness tear where you can actually see some fibres that are clearly taut, but then if you look, you have to look at different slices. So you look at the sagittal scans initially and then the coronal slices, so front on. And you might be able to see the anteromedial fibres being intact, but the posterolateral fibres have been injured. So that would be a true partial tear. But I think the true partial tears, the tears where the fibres are still roughly aligned, not sort of blown apart where some of the fibres have flipped forward out of the intercondylar notch and are impinging in extension. Then if that patient's in that middle ground, you're not sure whether they really need surgery or not, then I'm all for going down the path of a trial of non-operative management and following that patient, getting serial MRIs if I think it's got a chance of healing. I mean, the mantra has been the ACL doesn't heal. It's not quite true. And MRI has been really, really useful. And even some, as we were chatting before the session, even some grafts that are supposedly torn can heal. And to me, that's been a real eye-opener. I mean, I would have always thought that once a graft was ruptured, that was the end of it. But I have seen a few now where it's healed and people have gone back to sport and not had a problem. So
That's amazing. I mean, let's maybe talk about that a little bit down the track.
If we've got time, sure.
But one question I've got for you, Julian, is that middle third that you talk about, the people who are in the middle, they could go either way. You talk about the MRI and clearly, like we've already discussed, instability as the main driver to whether someone needs a reco. But do you actually have, the Frobel stuff says, for instance, 5 out of 10 will cope without an ACL. We'll talk about copers later as well. But with your crystal ball, can you pick it more than that? Do you get a gut feeling of the ones that can cope without an ACL and the ones that you go, I'll give them a go, but I reckon they'll be back in 6 weeks and I'll need to do an operation? Are there any other factors or any other things where you think, I'll give them a go, but I reckon I know which way this is going to go?
Definitely. I think there's different groups of patients that, in response to your question, there's one group who are absolutely insistent that they want a reconstruction.
Yes.
And if I don't think they need a reconstruction, that's a really difficult group. Now, it depends how tired I'm feeling, what time, whereabouts in the consulting session it is. Sometimes I'll just give up. Okay, you want an ACL reconstruction, I'm not going to fight you. I've done all the prehab, I've done this. Have you had any instability? No. Have you done most of the things you want to? Yeah. But I'll give up. But when I'm, not tired, not frustrated, I will try to have the discussion about, why don't you just see how your knee goes? If I was in your situation, I wouldn't have a reconstruction. That's really important information. I'm a surgeon. Essentially, I don't earn an income if I'm not operating.
Yeah.
So why would I give you the advice not to have surgery unless I really thought you didn't need it? Yeah. So that's one group. But I think you're talking more about the group where I think they probably will need something done. And to me, the pivot shift is a really good guide.
Yeah.
But I come back to the point that the pivot shift is hard to learn. The key is having the patient relaxed enough to be able to do a good pivot shift. And there's no point in saying try to relax. As soon as you try to do something, you don't relax.
Yeah.
And even with the Lockman test, so I like to, for instance, if I'm examining the left leg, I'm standing on the left side, and I just pop their foot over the side of the examination couch, and I've got my thigh against their leg, so my left thigh against their leg, and so they can feel that I've got control of their leg. It's how you talk to them, and just a bit of hands-on, gentle movement, and it's subtle. You don't have to sort of really force things with the Lockman, and the pivot's just the same. It's about getting them into the position and chatting to them and looking out the window and just doing it, and then you can sort of catch them unawares. And if they've got a grade 2 pivot in the consulting room, it's going to be really, really hard to return to any kind of sport that involves change of direction. And so they may not know it. They may be thinking along the lines of non-operative management. I'll say, look, I've got no problem with you trying. My prediction is you'll be back and have an operation. There may be other reasons why they can't have surgery at the time. They can't afford it, they're not insured, their work won't let them. There's school, lots of priorities. And that's probably something that I haven't emphasised yet. But to me, for the most part, ACL reconstruction's an elective operation. So this is being recorded during COVID lockdown, and well, not lockdown for the community, but a lockdown on elective surgery. And basically ACL reconstruction does not cut it as an urgent operation.
Yes. And
I think that's a sort of quite an important message. It's elective surgery. Timing is really at your leisure, just as long. And once you know it, you're not really going to go and do anything stupid, and you'd have to be pretty unlucky to do anything any further.
If you know what you're dealing with.
And then you need to know about the patient's expectations.
Yeah.
So part of my questions will be, do you want to go back to footy, for instance? Absolutely.
Yeah.
I'm not sure. We'll see how, so it's a mixture of patient expectations, demands, how their knee feels, a little bit of making a very judgmental assessment of their personality, how they'll cope without surgery. Some people they're going to need surgery just to get on with their lives.
You used a really interesting word before, and that was the word choice.
Yeah.
For the patient. As an expert and a clinician who's been doing it 30 years, people are coming to you to say, what do I need to do, Julian?
Yeah.
Whereas, there has to be some element, obviously, that it's the patient's choice as well. So how do you strike that balance between saying, this is what I think you need to do, but at the same time, like, you need to make your own mind up here?
I think it's really important that the patient chooses. And, another part of my practice is knee replacement. And I'm super conservative about doing a knee replacement. I want the patient to make the decision about when the time has come. So that translates also to ACL surgery. I can be pretty sure that they'll end up having surgery, but I like to make sure they understand what's involved in surgery. They've often got an incorrect idea about how disabling surgery will be in the first 2 or 3 months. I think if you can reassure them that it's really only a hassle for the first 2 or 3 weeks, that takes some of the fear of surgery out of it. So they're making a more rational decision about whether to have surgery or not. In the end, I do make the patient say they want to have a reconstruction. I think that also comes back to a trial of non-operative management. I mean, in a sense, there should be informed consent for non-surgical treatment, just as there is for surgical treatment. I think it's pretty easy because, as I said, you've got a diagnosis. You'd be unlucky to damage your knee, at least in that building up phase. But I do believe it's the patient's choice in the end. And sometimes it gets difficult with paediatric group. I treat really young kids as well, so 7, 8, 9, 10, 11 sort of age group, and that's hard when they're coming for a second opinion. And I'm not sure how much we want to focus on that group, but if their knee is loose, I think they need surgery. And because the big problem with kids is they recover so quickly from an episode of giving way that they almost don't notice it, and they certainly don't tell their parents, and they know they shouldn't be doing that, but they do it at school. And the trouble with that is they'll tear their medial meniscus, and if it becomes irreparable, that changes the whole natural history of the knee. So once you lose your medial meniscus, you are inevitably going down a path of osteoarthritis. Some might say you tear your ACL, you've got an increased risk of osteoarthritis, but we've had some long-term follow-up of patients, at 15 years, for instance, with no evidence of osteoarthritis. And we're currently doing a big study using MRI and looking at a big cohort to see if we can predict who's at risk of osteoarthritis. But there will be some times where I push really hard, but it's still the patient's choice.
Yeah, that's a great way of tackling it. Yeah.
So I think we've probably covered everything on that slide except the question about copers and non-copers.
Yes.
And this terminology is really interesting, and
it's been around for a while, hasn't it?
Yeah,
like at least 10 or 15 years.
Absolutely.
Yeah.
And a lot of it comes from Lynn Snyder-Mackler's group in Delaware in the US, and working together with Marianne Risberg from Norway. And they've done a lot of good work, investigating patients who haven't been treated surgically or in the lead up to surgical treatment. And unfortunately, I think the message from their papers has sort of gone through a bit of Chinese whispers, and what is said about, or their perception of what the papers are saying is not quite the reality. And so if you use the term COPA, the implication is that you're going to be able to cope with a torn ACL, and a non-COPA isn't. And when you look at the original studies where that terminology was used, really the way they classified COPA and non-COPA was how they responded to a battery of tests, which included hop tests and some strength and some questionnaires, I think, and balance. And you were allowed to have one episode of giving way in the previous 3 months, and then that would not make you a non-COPA, but then they rated how you performed on the tests. And if you performed well, you were listed as a COPA. If you hadn't, or you didn't perform well, you were a non-COPA. And they then looked at the effect of a 5-week strengthening program to see whether that influenced whether you were classified as a COPA or non-COPA. And I think, as you would expect, a strengthening program put more people into the coping group. But the reality is most of those patients went on and had an ACL reconstruction anyway. So what would be really interesting would be to have the same classification applied and then follow the patients out and treat them all non-operatively. That's a hard study to do because you're not going to get patients to sign up for that unless they really believe in non-operative treatment. But to me, a COPA is someone who copes with the knee where the ACL's torn. And Their level of laxity, not instability, their level of laxity is only part of the story. I mean, it's their sort of neuromuscular function and their activity profile, I think, which determines whether they can cope without an ACL or not. And people should also remember that most times we do, or pretty much every time we do a total knee replacement, except for very specific designs, we cut the anterior cruciate ligament out.
Yeah.
Everyone's ACL deficient when you've had a knee replacement.
There's a nice little snapshot from Randall and Julian's masterclass, and I really hope you picked up a couple of clinical gems there. Next up, we've got a short video here from Mel Haberfield's practical taping workshop. And in this video, you'll see some really simple ways to help you tape your lower limb injuries better.
So we're going to just start with a standard ankle taping because it's, pretty common, I'd say. It's one that we all would feel comfortable with. Has anyone done a standard ankle taping before? Who's done one in the room? Yep, everyone? Great. So if you just talk me through it while I'm cutting some of this tape, what do you guys think should be in an ankle tape? Anchor. Hey? Anchor, yep. Stirrups, yep. Sixes, great. Sounds good to me. And then if you want, you can do heel locks. Who's scared of heel locks? Anyone? They're hard. Heel locks are hard. And you just got to practice. I'm going to show you 2 ways to do them because the way my brain works is I get a bit confused, so I do them a special way. So maybe that will work for you too. So I'm just going to start with the fixie. As I said, you peel it off. We're just going to do that as an anchor. So with this tape, I'm just going to lay it on. And look, I've already got a wrinkle, so I told you I wasn't perfect. I'm just going to lay that on. And you probably saw that I just did a quick measure. We use this a lot at the footy club, so you may not use it. It's okay. I'm going to show you how we use it. We just rip it, because over the front here where the tendons come up through the shin, so you can see Jazz's tendons, that is where we'll get tape cuts and the athlete will not be very happy with you. So what we tend to do is literally just put a piece of microfoam there. You can put a piece of fixie there too. And then we tend to also put one at the back of the Achilles for when you're doing the heel lock, so it doesn't dig into your heel locks. And some of our athletes will be covered everywhere with fixie. That's fine as well. If they're really allergic, they need to fully cover. Time saving and cost saving. This is the quick version. So yeah, do that if it's easier. Might get you to bend. I should have taped that ankle. Sorry, Jazz. So if you can't see, literally gather around. So make sure you can see. I'm just going to get down on one knee. So important that we get the athlete to keep their foot in dorsiflexion with this one. So this is just a lateral ankle taping to prevent that lateral ankle sprain, which is really common in footy, basketball, netball, those type of sports. So I'm going to start with the stirrups. Interestingly enough, some people will put another anchor around. I don't, because this tape will stick to this tape. So that's just me being saving costs probably again. So you can do that if you want. That's absolutely fine. I'm not going to do it. We're going to start medial and we're going to go lateral. And the landmark we're going to use is the malleolus, and we're just going to go to the back half of the malleolus. Important when you do any taping, don't pull the force up and around. And you can see what I've done is I've actually taken the tape off the roll to take it up and around. I'm not ripping it as I go around, because what do you guys think? If I do that, what's going to happen? Yeah, I'm probably going to do that. She will not tolerate it. She'll get up and she'll say, oh, that feels really terrible. The good thing about ankle taping is because of the position of the joint and the properties of the tape will do the work. You don't have to do too much by pulling too much. There's other things that we will use the tape a bit more force, but this particular one, not so much. So yeah, I literally just almost lay it on. So see, again, tape off. I'm going to overlap by half and go like that. And because I'm in my bad habits probably, or not bad habits, but my habits are just to always stick the tape down. So I've just done 2 stirrups. You can see they overlap. If you've got a bigger ankle, do 3. That's absolutely fine. I'm just going to do 2. So I'm going to do a 6 now. So again, I'm going to start where the original stirrup was. And then basically we're just going to go up and over. So it starts where it ends where it starts. One of the 2. So, and again, you'll develop your own routines, whether you do 2 each side or 1 each side. It doesn't matter. It might be up to what the athlete wants. So just develop your own routines. Little trick, if you're turning corners, so come and have a look around this side, and maybe you too, Dion. If you're turning a corner and you're like, oh, that's going to go a bit funny, what you do is you just lift the tape here and you just place it where you want it to go. So then it looks pretty neat. So you can sort of help the tape turn a corner. But my trick is as well, don't force the tape. If the tape really doesn't want to go somewhere, it means you've got it on the wrong angle. You just follow where the tape really wants to go. I'm going to do a 6 the other way now. So again, just take the tape where it wants to go. And you can see I'm really not putting a lot of force into that tape. I'm just laying it on. I'm taking it off and I'm just laying it on, okay? So that straight away is basically your bare basic ankle taping. And for some people, that's plenty. That's all you need. If you've got your athlete who has had a few ankle injuries and they do feel really sloppy, then you will want to put some heel locks on them, because what the heel lock will do is it'll really, lock down that calc and make them feel stable.
How good was that from Mel? She's always so generous in her education for sports physios. Next up, we got a sample of Randall, Julian and myself's live Q&A session that we've held just recently. In particular, what you'll see in this video is a conversation we had about how we can improve flexion ROM post-op ACL reconstruction. But yeah, how far can we or should we push people into flexion? And by all means, Julian, you chime in too with your experience.
Yeah, I think it's a good question because, so much of the emphasis, and probably rightly so, is on extension and regaining extension after reconstruction. But I think that, like when you actually talk to the patients, most of them are obsessed about how much bend they're going to get in their knee. And if you can kind of get them going reasonably quickly, I think they feel comfort that they're improving quite quickly because it's quite noticeable. So I'll probably stay, and I'd be interested in Julian's thought on this, but I reckon that probably 8 or 9 out of 10 people regain their flexion without too much effort. So I don't think that it needs a heap of exercises. I don't think that usually, like in the initial phases of rehab, I might put 1 or 2 exercises in there to kind of get it going. And after about 2 or 3 weeks into that program, I'm usually getting a feel of like how easy that flexion is going to come. And if I think that the flexion is coming super easy, and you think about the hypermobile kind of young 16-year-old girl, I'll almost just leave it and just say, listen, it's going to come back, and we'll keep an eye on it. But I'd rather you focus on actually getting your quads going and your hamstrings. Then on the other end of the spectrum, you get those big older boys who are very fibrotic, and you know that it's just going to be a battle kind of on that front. With that population that's a little bit stiff, I then kind of subcategorize it into 2 groups. Is their knee angry, or is their knee stiff? Or is it a combination of both? Because if it's just that the knee is inflamed and hot and irritated, and they might be on a pathway to kind of getting, some regional pain stuff, sometimes it's almost, again, like hands off, ice, gentle range of motion, bike riding, that type of thing, just to try and get, some lubrication and an easy range of motion work, slide and glide into the joint. Whereas if it's just stiff, then that's, I think, when probably the only time that I get super aggressive. And what I mean by super aggressive is I don't do a lot of hands-on. I'm not one of those therapists that will kind of get the patient on their front, jump on their, and flex their knee like this, for hours on end, because invariably it just makes them worse. But normally what I'll do is add additional exercises into the program to try and regain flexion. So that might be, if they can't even get it over on the bike, for instance, a lot of bike riding, if they're at 120 degrees and they just want to get that last 10 degrees, it might be some prayer stretching and that kind of thing. But I don't think it's a one size fit all. And I think that regaining flexion generally is reasonably easy, but picking those hard ones is the art, and knowing what to do and when to do it is kind of the art in the science. Yeah. Julian, have you got any other comments on that?
In general, I completely agree with what you're saying. I think I'm amused sometimes when I see patients for sort of their final follow-up and then they're doing a quad stretch and so they haven't quite got full flexion, and they're way past 145 and you're thinking, how much do you really want? But I think it's true. Most people will get their flexion. I'm a huge fan of the stationary bike, as people who've worked with me would know. And it's pretty much, there's almost no contraindication apart from maybe a meniscal repair in terms of getting on a stationary bike quite early. And I like the bike, even if it's just rocking backwards and forwards, just to sort of, there's something about that repetitive motion that seems to get the knee moving without much stress. And I completely agree that really leaning on the knee, flexion or extension, might give you 5 degrees during the session, but the next morning the patients have lost that, the knee's sore again. And effusion is pretty important because a moderate effusion will block flexion. The knee just feels tight, and then you need to ask yourself, why is there an effusion? You shouldn't really have much of an effusion beyond the sort of 4 to 8 week mark, depending on how the knee was at the time of surgery. And effusion at 3 months is starting to concern me. You can have a very small effusion, but I start to ask myself what's going on. And the commonest cause is a cyclops lesion because they haven't got their extension, and that's starting to irritate the knee. I don't think the graft is a concern in terms of pushing flexion. I mean, when we do the procedure, I routinely take the knee through 10 cycles of full extension and flexion with traction applied to the graft. And then once the graft is fixed, I do it again, not 10 cycles, but just take the knee to full flexion just out of habit. So if it's going to damage the graft, I've already damaged it in theatre, but it shouldn't at all. So I don't think that's a concern. Probably extension is the thing that I think of most, but you're right, there's a few patients. And going back to the lateral tenodesis, I haven't worked out who's at risk, but there's definitely a subgroup of patients who, if you do a lateral tenodesis with a primary ACL reconstruction, struggle with both extension and flexion. And they're the group where I might end up doing an arthroscopy to clean out a cyclops lesion, but also suprapatellar adhesions that have formed and are blocking flexion. So it may be tied up with how stiff their knee is, how big the graft is, what sort of graft you've used. If it's a stiffer graft, maybe that, quads is stiffer than patella tendon, which is stiffer than hamstring, or a big graft might be filling up a lot of their notch. So I think surgically, I'm starting to think a little bit more that, bigger isn't necessarily better. That's been a bit of a mantra for a while, but once you get to a graft diameter of 8 millimeters, 8.5 millimeters, they're pretty small gains for a bigger graft. But I'm sure we're going to come back to extension, so I'll leave that for the moment.
Might just follow on. I mean, I know that the masterclass was on the surgery in the early stages of ACL rehab, but I think the biggest conundrum for me when it comes to flexion is right at the end. And if people haven't got that last kind of 2 to 5 degrees, so if they do get to 140 degrees and functionally you're happy with them and they can do a full squat and they've ticked all the other boxes with strength and neuromuscular function, hopping, etc., but they're just missing that last little bit, the perfectionist in me says, I want to get that back because I want to restore a normal knee as best I can. But then I suppose the pragmatic side of it it probably doesn't matter unless you're a wrestler or a mogul skier, for instance. So maybe I know this is about masterclass for me and Julian. But Mick, I might throw that one back to you. And is that something that you wrestle with? And if you do, like, how do you tackle that last little bit of flexion at the end if they haven't got it? How do you address that?
Yeah, I agree on all your points. I think there's no great need to go chasing flexion aggressively early. And then that last stage too, like you said, that last 5 degrees is really tricky to get. The other person population, I think, might benefit from that full range flexions, like a top level elite sprinter, maybe a soccer player, fast, striker, AFL player is pretty quick and nippy, who wants that full flexion and that nice hamstring ability. Look, I don't have any magic tricks, to be honest, other than making sure that on top of trying to get that flexion range through both, I like using like a full squat or a leg press initially, and any kind of curling type action will naturally just encourage more hamstring extensibility, both in extension and flexion. I often find they probably do the most part. Yeah, they'll probably get you 95% of the way there. You can do your kneeling stretch, the prayer stretch stuff you talked about. Reverse Nordics, I find it quite nice. They hit the quads, but then also too, you're sitting on the knee and really deep flexing the knee at the same time. I'll probably go back to what Julian alluded to before and said, like, you probably just need to ask yourself, is there a little effusion there at the back of the knee stopping that full flexion? If there is, maybe we need to address the rehab as well and maybe sort of tone it down a bit, because it just might be sparking up an effusion there quite subtly that's stopping you get that end range flexion. I think 95% of the people that you will rehab, you probably don't need that last 5 degrees. So you probably just need to sort of, just take a deep breath and just realize that some knees may not restore that full flexion, but those that can get it, I think there's just a few little simple things there that you can sort of work to. I like all that kneeling stuff, and definitely isolated hamstring work. I think that's actually really underappreciated when it comes to hamstring rehab and trying to get range back. And I think we often, the rehab side of things moves towards the deadlifts and that kind of stuff. We know hamstring curls, Nordics, any kind of flexion-based hamstring stuff is super important to restore that range, as is that isolated quad work too. We know that, you're going to, you actually naturally do get some length in your tissues once you've got your muscles nice and strong. And certainly if you focus on the eccentric component of your strengthening training, you get some nice subtle length changes there within the muscle fibers. So I think there's some simple things there that we could all do without being super aggressive.
And there you have it, everyone. A snapshot of a standard month of the Teams program rolled up into a neat little package. If you like what you see and you're interested in joining the Teams program, click on the link below and speak to our Teams coordinator today.